Hello and welcome to my YouTube channel, AnatomyMentor. I'm going to discuss today the development of the cardiovascular system, and this is the second part of a series of lectures, the embryology lectures, in which we are covering this topic in certain segments. So in today's session, the learning objectives are that at the end of the session, you should be able to draw and explain the septum formation in the common chambers of the heart, namely the atrium and the ventricle. And also we shall discuss septum formation in the outflow tracts, that is the truncus arteriosus and conus cordis regions of the heart. And also we're going to discuss the process of valve formation and then correlate the abnormal development of septae and endocardial cushions with heart defects. So these are our learning objectives for today. And before starting with the detailed topic, let's just give an intro in which we should have an idea that last time we were talking about the formation of the heart, which begins with the formation of a structure known as the heart tube. Now, this heart tube, several dilatations appeared within this heart tube that give rise to the different chambers of the heart. Now, the septae are you could say simply the walls or the parts which are going to separate those heart chambers from one another. So if you compare the human heart with a house with the chambers as the rooms, then the septae are simply the walls between those rooms. And it is in the fifth week of development that the major septae of the heart, they are going to be formed. Now, regarding the formation of these cardiac septae, keep in mind a few general rules. And these rules are that you've got septum formation, which occurs by the process of the ridges that approach each other until they become united. And these septae, which are going to be formed by this method, this happens in the common atrioventricular canal, and it also happens in the conotruncal region. Then the other method by which the septae might be formed is when there is a single actively growing cell mass, and this is the process which takes place in case of the interventricular and atrial septae. So here you can see that this is a common passageway, and we are going to if we want to form a wall between this passageway, then either of these two processes can take place. We can have two actively growing masses approaching towards each other. They are known as the ridges, or you can have simply one ridge or one actively growing mass which is approaching the other side of the common chamber. And then there's another method in which there is no actively growing mass, but it is actually the wall itself which is expanding, and that causes the appearance of the septum. And this is the method of septum formation that takes place in the ventricle. Now I'm going to draw in a detailed stepwise fashion the processes which take place, which are responsible for the septum formation in the common atrium. Okay, so remember that at the end of the fourth week of development, we have a common atrium. Now, this is the compass over here. This is just for an orientation of the direction to give you an idea that this is towards the right, the left, superior, and inferior. So over here now, I'm going to draw the heart in early stages of development. That is in the end of the fourth week, in which we still have a common atrium, okay? And so this here is the common atrium, and just below that you can see is the ventricle. And the ventricle, it has a thick muscular wall. Now, if we focus on the common atrium, and between the ventricle, we have these early embryonic tissues which are known as the endocardial cushions. Now, this here common atrium, what is going to happen in the end of the fourth week is that a crescent-shaped fold is going to appear from the roof of the common atrium, and it is going to grow in a downward direction towards these endocardial cushions, that is towards the common atrioventricular canal. But it does not reach it entirely, and a space remains between this septum and the endocardial cushions. Now, this septum is known as the septum primum. Okay, so this is the septum primum, which has grown from the wall of the common atrium, and the roof, that is the roof of the common atrium. And this space or gap which has remained over here between the lower edge of the septum primum and endocardial cushions, I'm just going to label this over here so we remember what we're talking about. This gap is known as the ostium primum. Now, the word ostium just means opening. So this is the septum primum, this is the ostium primum. Now, this is the common atrium, and this here is, you see, the right-sided future atrium, and this is the left-sided future atrium. Now, let's look at what's going to happen later on. Now, later on, what happens is that the endocardial cushions, they are going to grow upwards towards this septum primum, and they're going to fuse with it. But meanwhile, within the upper part of the septum primum, you can see that because of cell death, another opening has appeared. Now, this opening is known as the ostium secundum. This opening has appeared in the upper part of septum primum. And now, if you remember from the previous lectures, I told you that the right horn of the sinus venosus, it gets incorporated into the right atrium. So because of incorporation of the right horn of the sinus venosus into the right atrium, its lumen is going to expand. And as its lumen expands, you can see over here, as its lumen expands, it causes the appearance of another fold from the roof of the common atrium. Now, this is known as, this ridge or this septum is known as the septum secundum. But this one doesn't completely grow downwards. It just remains in the upper part of the common atrium, but it is responsible for a partial overlapping of this ostium secundum. And this ostium secundum now becomes a passageway for the flow of blood from the right atrium to the left atrium. Because of the higher pressure on the right side, the blood is going to flow from the right to the left atrium through this opening. And this ostium secundum is now known as the foramen, which then again means opening, ovale, the foramen ovale or foramen ovale. So this is now the gap or the passageway between the right and left atria during embryonic and fetal life. And also remember that the lower half of this here septum primum is known as the valve of foramen ovale. So the important thing to remember is that the foramen ovale itself is derived from the ostium secundum, whereas the valve of the foramen ovale, this is derived from the septum primum. So these are the diagrams which are showing you just what I drew. That was the septum formation in the common atrium. And these diagrams have been taken from Langman's Medical Embryology. And you can also see this from a sagittal section. You can also study these in detail. So like I told you, the foramen ovale is derived from ostium secundum and its valve is derived from septum primum. Now, before birth, the function of the foramen ovale is that it allows most of the oxygenated blood entering the right atrium from the inferior vena cava to pass into the left atrium. Now, after birth, when lung circulation begins, you know the pressure in the left atrium will increase, and that will push the valve of foramen ovale against the septum secundum. And this obliterates the foramen ovale and it separates the right and left atria. This obliteration in the beginning of life is functional. In 20% people, the foramen ovale remains patent, and that is known as the pro-patent foramen ovale, which is usually asymptomatic. So if the permanent closure of that foramen ovale doesn't occur, then that means there is going to be an opening in after birth between your right and left atria. And this is simply known as the hole in the heart. And it can be symptomatic and we will talk about the atrial septal defects as well. You see over here, this is the patent foramen ovale. It is the passageway which is still open after birth between the right and left atria of the heart. Normally, as I told you, this opening is supposed to close. It closes functionally before it closes anatomically. Now, if we talk about the atrial septal defects related to this anomaly, so there are different types of atrial septal defects. Ostium secundum defects, they are the most common ones. That's the one that I just showed you because of the persistence of the foramen ovale, because the foramen ovale is derived from ostium secundum. It can occur due to a number of reasons. One reason could be excessive resorption of the septum primum or absence of septum secundum. Ostium primum defects can also occur. In this case, it is, if you recall it, I had told you that the endocardial cushions, the superior inferior ones, they grow towards the septum primum, closing it inferiorly. If these endocardial cushions fail to grow to seal off that ostium primum, then that can cause the ostium primum type of atrial septal defect. Also, the atrioseptal defect might be located in the uppermost part of the interatrial septum, and that in that case, it is known as the sinus venosus atrioseptal defect. And this is because of the abnormal absorption of the sinus venosus horn into the right atrium. And the most extreme form of atrial septal defect is the complete absence of an interatrial septum. And that case, it is known as common atrium, or the medical term for that is core trilocular biventricular. So here, these are the diagrams which are showing you the different types of atrial septal defects in comparison with the normal. So you can see over here, in this case, this is the most common type of AST, which occurs due to the excessive resorption of the septum primum, which has left an abnormally large ostium secundum. And like I told you, it can also be because of the absence of the septum secundum. Then the less common type is the atrial septal defect, which is the one due to the ostium primum, in which the endocardial cushions fail to fuse with the septum primum. And this is, you can see in the lower part of the interatrial septum. And then the uppermost part of the atrial septum that can also have the defect or a gap, and that is known as the sinus venosus AST, which is a less common variant. And now we're going to discuss septum formation in the atrioventricular canal. Now, keep this in mind when we're talking about the septum formation in the AV canal, that is the atrioventricular canal. Initially, the AV canal gives access only to the primitive left ventricle. So here you can see that this is the opening, this is the passageway, which is the initial communication between the common atrium and the left ventricle, which is derived from the primordial ventricle. And over here, this structure is known as, this ridge is called the bulboventricular flange, and it separates the left ventricle from this area, which is known as the bulbus cordis. The bulbus cordis, if you recall from the previous lecture, it gives rise to the right ventricle. So right ventricle and future left ventricle are separated by this here bulboventricular flange, and the left ventricle is communicating with the cavity of the common atrium through this passageway, which is the common atrioventricular canal in the initial stages of development. Later on, this common AV canal is going to be subdivided into two distinct separate openings or passageways, which will be between the respective ventricle and atrium. You can see over here, this is the right atrioventricular canal. So this is the opening between the right atrium and right ventricle. And here is the left atrioventricular canal, which is the opening between the left atrium and left ventricle. So this single opening over here has been divided into two separate openings because of the appearance of this here septum in the middle. Now, the appearance of the septum, I told you before that there are different methods by which the septi appear. And one of those methods is when the actively growing ridges or tissue masses appear in the walls of the passageway. and as they approach each other towards the middle, they are eventually going to fuse, and this creates the septum, therefore subdividing the common AV canal into two separate, that is the right and left AV canals. So here we can see the ridges which fuse and make this separation possible are the superior and inferior endocardial cushions. The superior one is also called the dorsal endocardial cushion, and the inferior one is also called the ventral endocardial cushion. Two lateral endocardial cushions also appear, but they do not fuse and they are smaller in comparison to the superior and inferior ones. Now, also another event which is going to take place is the formation of the atrioventricular valves. Now, you know, these are the bicuspid and tricuspid valves, and here are the series of events which are involved in the formation of these valves. So this is the wall of the inner wall, the muscular wall of the heart, that is the myocardium, and in the ventricular region, you can see over here that this is a thickened area, and what's going to happen is because of the flow of blood, this is going to start thinning out, and you can see that now the papillary muscle has become prominent and it is connected to this fibrous tissue, the dense mesenchymal tissue, through these strings which are the chordae tendineae. And these dense fibrous tissue regions, they are going to form the atrioventricular valves, which are attached to the ventricular wall through the chordae tendineae. There might be some abnormality with the formation of or the subdivision of the common AV canal into right and left AV canals. Then in that case, the condition would be persistent AV canal. So here you can see where in which case the septum has not properly appeared. Then you can see there is still a common passageway, that is the defect over here, which is the large defect, and there is an AST as well as a VST, and so this is the persistent AV canal. Now let's talk about the septum formation in the region which is the truncus arteriosus. This was the uppermost part of the heart tube and also the uppermost or the cranial most part of the bulbus cordis. And in this region, two swellings appear which are known as right superior and left inferior according to their position. These swellings will twist around each other and fuse to form the aorticopulmonary septum. So if you recall, you remember that truncus arteriosus is the part of the heart tube which gives rise to the initial portions of the large channels, the aorta and the pulmonary trunk. So when two swellings appear inside its wall, the right superior, left inferior, their fusion results in the formation of the aorticopulmonary septum that is going to subdivide the truncus into an aortic and a pulmonary channel. Now, just inferior to the truncus is the conus cordis, which is also part of the bulbus cordis. Here also two swellings appear, which according to their position are right dorsal and left ventral. And they will grow towards each other and they will fuse to subdivide the conus cordis into the two outflow tracts of the ventricles. The anterolateral outflow tract is that of the right ventricle and the posteromedial outflow tract is that of the left ventricle. And also distally, these conus swellings are going to fuse with the truncus septum. So here we can see this is a frontal section through the heart of a 35-day-old embryo. And at this stage of development, you can see the blood from the atrial cavity will enter primitive left ventricle as well as the primitive right ventricle, because over here the AV canal, the passageway is still common. It hasn't subdivided at this stage. But let's look at the cushions which are appearing in the conus region and also in the truncal region. In the conus region, you've got the right dorsal conus swelling and the left ventral conus swelling. And over here, then cranial to that, in the truncal region, you have the right superior and the left inferior truncus swellings. So as I told you, these swellings are approaching each other, and as they will fuse, they will result in the formation of a septum, which will subdivide this section over here into two separate portions. Also, we can see the superior and inferior ridges, endocardial cushions are also developing in the common AV passage to subdivide it, as we can see in the next stage. If you look at the next stage, that is a 7-week embryo. This is a frontal section through the heart. Then we can see that over here in the conus region, the swellings have fused and they have formed the conus septum, and that is in continuity with the truncal septum. And over here also we can see that now we have the right and left ventricle. They have their separate openings into the atria. Also note over here, this is the thick interventricular septum. So here these are the diagrams which are showing us the formation of this here conotruncal septum. And this conotruncal septum, now I'm going to collectively call it conotruncal septum. The one in the conus region, the one in the truncal region, they are fused into the conotruncal septum. It has subdivided this outflow tract region and the region directly above it into two separate channels. And these two separate channels, as I told you before, in the truncal region, the separate channels are representing the aorta and the pulmonary trunk. And in the conus region, these separate channels are representing the outflow tracts of right and left ventricles. And another thing, an important thing to keep in mind is that this conotruncal septum is going to spiral. It has a spiral course, you can see, and because of this spiral course, we can see that the outflow tract of the right ventricle, that is going to be anterior to the outflow tract of the left ventricle. So eventually in the adult heart, you can see that this pulmonary trunk, it is emerging from the right ventricle and it is placed anterolateral to this here aorta, which is posteromedial. It is posteromedial to this here pulmonary trunk. Now, when we talk about the aorta and the pulmonary trunk, we know they also have valves, and they are the semilunar valves. Their origin is simply from the minor swellings which are going to appear in the truncal region, and then these swellings, they are eventually they're going to approach each other. And you can see over here that these semilunar valves, they have appeared in the region of the aorta and also in the region of the pulmonary artery. So another aspect of the same process, these are the valve swellings appearing in the wall of the endocardium, and eventually because of the flow of blood, they are going to be leveled out into this anatomical structure, which is the valve cusp. Coming now to septum formation in the ventricles. Now we know the ventricles are the largest chambers of the heart, and there are two parts of, remember, the interventricular septum. This septum is going to divide the common ventricle, that was the primordial ventricle, right? And then we also have the right ventricle, which appears from the bulbus cordis. So right ventricle appears from bulbus cordis and the left ventricle appears from the primordial or primitive ventricle. And they are going to be separated by the interventricular septum, which, remember, has two parts, a muscular part and a membranous part. The muscular part is formed by apposition of medial walls of expanding ventricles, whereas the membranous part is formed by the growth from above by the inferior endocardial cushion, which closes the gap or foramen along the top of the muscular interventricular septum. So we can understand this by then again looking at a frontal section through the heart at the end of the 7th week. You can see these are the right and left ventricles. The left ventricle is a thicker and has a thicker and a more, you can see, prominent muscular wall. And this is the muscular part of intraventricular septum. Now, this appears by the process that I just told you because of the expansion of the right and left ventricles. So as the walls expand, this creates a ridge between them, and this is the muscular part of intraventricular septum. Whereas the upper part of this interventricular septum, this is membranous. This is formed by the growth of the inferior endocardial cushion, which grows in this direction downwards to close the interventricular septum from above. Now that we've discussed the formation of the septae in different parts of the heart, let's talk about the abnormalities which can occur in conotruncal region. Well, one abnormality that you should be familiar with, that is the Fallett's tetralogy. This is an abnormality of conotruncal region due to an unequal division of the conus, which results from anterior displacement of conotruncal septum. So that is going to cause the characteristic 4 features of the Fallett's tetralogy, and that is number 1, you can see the pulmonary stenosis, that is the narrowed lumen of the pulmonary trunk. This obviously causes the right ventricle to pump with a greater force, and that will cause the right ventricular hypertrophy, which is the second feature. Also, there is an overriding aorta, that is the aorta which is just sitting on top of this gap between the ventricles. So overriding aorta is the third feature, and interventricular septal defect is the fourth feature. These are the four features in the congenital heart defect, which is known as collectively phallic tetralogy. And this is just a picture which is going to help you remember. It's like a mnemonic, because when there's phallic tetralogy, there is a boot-shaped heart which is visible in the radiograph in the X-ray, and that's because of the right ventricular hypertrophy. So the overall shape of the heart is like that. And over here you can see the VST, the overriding aorta, and the pulmonary stenosis. Another congenital heart defect is persistent truncus arteriosus. Now, as the name shows, in this case, the truncus has failed to subdivide. It is an undivided truncus because the conotruncal ridges fail to fuse, forming the septum. And it is always accompanied by a defective interventricular septum. So you can see there is going to be a VST, ventricular septal defect, and here the region of the truncus, it is a common truncus, it is undivided. And these conditions, they cause mixing of oxygenated, deoxygenated blood. So very early, the presenting signs could be cyanosis and shortness of breath and difficulty in regular activities. And now another defect is the congenital heart defect, which is transposition of the great vessels. Now this happens when the conotruncal septum fails to follow its normal spiral course. As I told you, the septum is supposed to spiral around itself, but if it doesn't spiral, then what is going to happen is that the aorta will originate from the right ventricle and the pulmonary trunk will originate from the left ventricle. And this is sometimes accompanied by a defect in the membranous part of interventricular septum. But it is usually accompanied by an open ductus arteriosus. So here you can see the aorta is emerging from the right ventricle, the pulmonary artery from the left ventricle. So this has been reversed. And also there is a patent ductus arteriosus, the channel that is the communication in fetal life between the aorta and the pulmonary trunk, which is supposed to close after birth, is still open. So that's the patent ductus arteriosus. And this is known as transposition of great arteries. Now that we've covered the topic which is related to the formation of septae, as I told you, the septae are going to be formed in the 5th week of development in the heart. And we can check the integrity by the cross sign in ultrasound scans of the heart. So the cross sign is simply, this is a marker for checking the formation, the normal formation of the septa of the heart. So in echocardiograms, we focus on that region which is forming the septae. It appears in the form of a cross, which is indicating that normal septae have formed between the atria and the ventricles. And neural crest cells, they have an important role in formation of these septae because the endocardial cushions, which we just saw, have a key role in formation of the septa of the heart. Those endocardial cushions are derived from neural crest cells. So any congenital condition, any genetic condition otherwise, which causes abnormality in the migration or function of the neural crest cells is also going to cause defective septal formation in the heart, and that can be a part of a spectrum of abnormalities related to the neural crest cells. So that concludes with the second part of the development of cardiovascular system. In today's session, I have covered the discussion on the formation of the septae in the heart, that is in the common atrium, the ventricle, and also in the conotruncal regions. And we also discussed a few of the congenital heart defects. So remember, the congenital heart defects, their correction would be surgery because they are going to be surgery corrected in the early years of life. Now we are also I'm going to upload the third part of my series of lectures on development of cardiovascular system soon. And if you found today's discussion helpful, don't forget to like and subscribe to my YouTube channel, Anatomy Mentor. And you can do that by simply pressing on the picture, which is going to appear at the end of this video. And also don't forget to hit that bell icon for regular updates. And best of luck for your exams. And I'll also be sharing a few MCQs at the end of this series, MCQs related to development of the cardiovascular system. Take care, stay blessed.